Okay, so as we said, the scenario is, I assume, a healthy, surgically fit 62-year-old gentleman who would prefer to spare his bladder but has muscle-invasive disease. So, and as Dr. Singh pointed out, there's bladder preservation in the form of concurrent chemoradiotherapy after maximal TURBT is a category 1 recommendation. So, and I'm not going to completely hate on the idea of bladder preservation. I think it's a very reasonable approach, especially the medically unfit population, which many bladder cancer patients are. I feel it is a good alternative to immediate cystectomy. So patients are delaying their decisions, for either personal reasons or access to care reasons. I think is a good option for them instead of not being treated at all. And there is proven data that there is higher survival with bladder preservation rather than palliative treatment. So, but this is obviously very dependent on many factors: location, the size of the tumor. Obviously, patients with large, bulky, extravesical disease are not going to do as well. The status of the urothelium, does the patient have multifocal CIS, unifocal? You also have to consider, these patients have had possibly many intravesical therapies, many resections and biopsies. So, bladder compliance and capacity, bladder pain. I think all this needs to be into consideration. And in histology, obviously, we don't have much data on variant histology for bladder sparing treatment. So, in my opinion, the big limitations for bladder sparing, there is a paucity of prospective trials. Needless to say, like Dr. Singh correctly pointed, there will never be a randomized controlled trial head-to-head, right? So, but for me, it's a positive prospective trials. Many of these data that we have are just for retrospective, oftentimes single institutional series of patients. We know that we could salvage these patients with a cystectomy. However, we don't know how these patients do. There's limited knowledge on what happens to these patients after delaying their cystectomy. There's a lack of biomarkers, although circulating tumor DNA. There's some newer technology nowadays, perhaps. But in my opinion, the biggest limitation is the lack of clarity for complete response. As we know, clinical response is not the same as pathologic response. And then at the end of the day, surgery is still needed, right? These patients need to be endoscopically free of tumor. However, we know that many bladders can be clinically understage after TURBT. And I really like this study from the Fox Chase Center. This is a prospective trial where they had 61 cystectomy patients undergoing what they call systemic endoscopic evaluation, or C, basically a cysto and bladder biopsy at the time of prior to the radical cystectomy. And so almost half of these patients actually had no visually evident disease or biopsy proven disease. So they call this CT0. However, about 51% of these patients ended up having residual disease, and about 25% had actually invasive disease at time of cystectomy. So this trial was stopped for futility because of such a horrible negative predictive value. Needless to say, there's more than meets the eye for many of these patients. And so I mentioned before, there is no head-to-head prospective randomized control trial comparing bladder sparing versus cystectomy. And I know Dr. Singh highlighted this probably the only large study comparing these two approaches head-to-head, although this was in a retrospective fashion using some propensity score matching and some sensitivity analysis. This is a multi-institutional study. It was led by the folks at Toronto, I want to say, and obviously collaboration with MGH, Mass General, and I think other groups. I think USC and UCLA were also on there. So the cohort was of almost 722 patients with muscle-invasive disease who would have been eligible for a trimodality approach or cystectomy. About 440 underwent cystectomy and 282 underwent bladder sparing. And their end results basically show equivalent metastasis-free survival, disease-free survival, and cancer-specific survival. So I know this paper had a lot of press. I know there are a lot of centers were talking about this in their journal club. So I thought, it was, it's what we have. But I think one really, as Dr. Lee knows, I'm very critical during journal club, and I like to look at the data, in detail, in depth. And so I think, as if you were a patient, I think seeing the survival curves, for metastasis-free survival, cancer-specific survival, disease-free survival, they're very nice, right? I think you could easily sell a patient showing them these curves, and you could make the point like, oh, wow, I could keep my bladder and live just as much as a cystectomy patient. And I have seen some local radiation oncologists bring these specific studies to them. So. But I think, and then as the methodology of the paper said, there was propensity score matching. So they try to balance this for stage and age and gender. And so, but I think something that jumped out at me immediately was, almost the 90% of the cohort, a great proportion of the patients were actually T2. And so I think this paper, these results were really only applicable for a very select few, very highly selected group of patients. So, this doesn't apply to your, commonly seen large bulky disease bladder cancer patient, in my opinion. Also, I thought it was interesting in this study that almost 56% of the patients in the trimodality group underwent full neoadjuvant systemic chemotherapy, which I thought, that's not typically what you consider chemoradiotherapy, right? They get a different kind of radiosensitizing chemotherapy. And so, however, these patients receive full induction. So, I thought it was also interesting. And then lastly, looking at their sensitivity analysis very closely, it's hard to miss how the blue curve or the trimodality group immediately started higher than the surgery group. And so that pattern almost repeats in every single curve. So looking at this is really, kind of caught my attention, like, that let me know that there are almost no events. No patients died the first few months after, in the TMT group. There were no recurrence or progression rates or events. And so as opposed to the surgery patients, the red curve, which started immediately lower than the blue curve. And that also obviously accounts for the mortality of radical cystectomy in and of itself. So that let me know that these patients were, even though this was a propensity score match analysis and all that, you could do all these very intriguing statistical modeling. Even then, these patients were almost, I think, guaranteed to have a good outcome. If you're already starting with no recurrence and no progression, they were guaranteed to at least survive their treatment, which doesn't really happen in cystectomy patients. So patients also die from having chemotherapy, or dying from their disease itself if it's rapidly aggressive. So, in my opinion, that's how I saw these curves. The TMT curve was already a head start on the radiation curve, on the surgery curve. I'm sorry. So. And then, sorry, I'm harping on this paper because that's the only head-to-head comparison. So I couldn't really find any other head-to-head comparison. So, and then reading the results of the paper, 13% of these patients ended up having cystectomy. These patients were in the TMT arm, and so yet they still remain in the TMT group even though they had surgery. And so even though they still survived and had their good outcomes, I just thought it was a little interesting that it wasn't, that you still have to have, a little bit of a crossover there. And then focusing on the surgery patients, I'm a surgeon, and so I think the pathologic results really caught my eye. Almost 44% of these patients had locally advanced bladder cancer, T3, T4. and almost 26% had lymph node positive disease. That's actually a pretty high number. And so this, to me, this suggested that almost all a great proportion of these patients either had residual muscle-invasive disease or node-positive disease after the induction chemotherapy. So even though the study was propensity score match and they're supposed to be clinical T2, I suspect that likely patients that did not respond to chemotherapy well were probably pushed to having surgery. So you can't really say they were, I think that it's confusing to suggest that you could possibly randomize people in a future study. So, and then the operative outcome was actually really great. Despite having such high risk muscle-invasive bladder cancer, at T3, T4, lymph node positive disease, despite having these such aggressive features, the 5-year cancer-specific survival was 83%, which is pretty dang good. Pretty dang good for such an aggressive cancer. And then positive surgical margin rate, only 1%, 2.5% perioperative mortality for cystectomy, which is also pretty good. A lot of these patients came from USC and UCLA, I think. So I think so. My take-home points are, I think chemoradiation is a wonderful option in the keyword appropriately selected patients. I think the important point is the shared decision making. Obviously, you gotta have a multidisciplinary approach to these patients because if they opt for this option, they will need a rigorous follow-up and some degree of infrastructure to follow them up. And so I believe you can only offer this option at a center that is comfortable following these patients, and they're also comfortable and have the expertise for post-radiation cystectomy. So with that, I want to say thank you very much, guys.